recording this and get your question, and if I can't get to you, I'll just repeat your question so that it's caught for the recorded presentation. And then we'll have a little time afterwards too if you need to talk to somebody. Also, don't let me forget, I get on autopilot and we get done, I may just be like, man, I'm glad this is over because everything went well and I didn't mess up. Don't let me forget that we've got a drawing for a home blood pressure monitor, so if I don't say something at the end, say, hey, do the drawing for the blood pressure monitor before we leave. So anyway, I'll start with our panel. Down at the far end there we have Dr. Aravind Pothanini, who is a pulmonologist. We have Mary Morton, from a sonographer and works in the sleep lab and does the sleep studies. We have Elizabeth Hunefeld, who is a nurse practitioner at Cardiovascular Consultants at our cardiology group. We have Billy Thatcher, who is the director of respiratory therapy and the sleep lab. And we've got Dr. Drew Satterfield, who's a primary care physician. So we'll, and I've seen some of you already waving at people because you're already their patients. So we'll start with Dr. Satterfield and let him kind of talk about how he fits in, and we'll kind of go down the line and then we'll open it up for questions.
All right, so I'm the one that pretty much keeps everybody else busy for the most part. You know, when patients come to me if they're concerned about sleep apnea, either they are saying they're usually the guy with his wife and his wife saying he snores all the time. Is what typically happens. The patients will typically be complaining about being tired during the day, taking naps, falling asleep easily, and those are usually the main symptoms that I hear. And kind of my job is to triage that and decide if that does sound like something that is sleep apnea and whether there's a further workup that's needed. And typically with that is usually either a home sleep study or an inpatient or in-lab sleep study. And that's where kind of everyone else comes in here. So I'll go ahead and let them talk about that.
Yeah, my name is Billy Thatcher. I'm the director of respiratory therapy in the sleep lab. So if you come to have a sleep study at the hospital, don't expect to see me up there. I'm more of a support role in the executive team. Sorry, get too far away. All right. So in my position, I need to make sure Mary and the staff in the sleep lab have the correct equipment, the things that they need. When they need a new staff member, I'm involved in onboarding new polysonographers. This April, we put in all new software and sleep lab monitoring equipment. But I guess that's...
Okay, Elizabeth?
So a lot of people ask, why are they having cardiology do a sleep apnea panel? And the fact is that we actually order a lot of sleep studies. The same risk factors for sleep apnea are similar risk factors for heart disease. And sleep apnea makes it a lot harder for us to control hypertension, and also makes it a lot harder for us to treat atrial fibrillation, and is a risk factor for atrial fibrillation. So a lot of what we do in cardiology is preventive care. And one of the ways to prevent atrial fibrillation, for example, is to treat your risk factors for heart disease, and one of those being, and also making sure that if you have sleep apnea that you're treating it. So.
Okay, Mary?
I work the day shift in the sleep lab. The girls that work the night shift are the ones that you'll actually be seeing the most of. My responsibilities are primarily scoring the sleep studies that are recorded at night. I condense about 1,000 pages of information down into about a 6-page report that Dr. Pothanini or his partner read and interpret. I also set up home care equipment. We do Cpap, Bipap, home follow-up. If you come in our lab and have a positive diagnosis and we set you up with home equipment, we will follow you for a year. We will be calling you periodically throughout that first year to check on you and make sure that things are going okay, and if you're having any problems that we can address those. to try to take care of them quickly and efficiently. I do the education also and setups for the home sleep testing, and also download that data and then condense those reports down for Dr. Pocanini and his partner Reed.
As a sleep physician, I guess, look at the sleep studies and manage whatever treatment they require.
Okay, well, we'll go ahead and open it for Q&A. And so any questions?
I have a question.
Yes, sir.
I don't need that, I can.
Well, we're recording, so that actually helps. It actually helps a little bit.
My wife says I snore, and I know I've stayed away from that, do not snore. Just because you snore does not mean that you have sleep apnea, is that correct? I mean a deep snore, a waking up snore.
That's correct. Yes, that's correct.
Okay, did you hear that?
But having a spouse notice some irregular breathing or a pattern of stopping, starting is almost 60 to 70% predictive of sleep apnea. So pay attention, I guess, to the spouse.
I didn't think that of this, all the topics we do, this is one we should probably have some marriage counselors outside. Things. Next question. Yes, sir.
What is sleep apnea?
It's a repetitive obstruction at the back of your throat that causes a decreased airflow or a complete cessation of airflow that then has further consequences down. So that's obstruction of the obstruction. It's happening at the back of your throat, and it's only in sleep. So that's sleep, and apnea is ineffective breathing, you could say. So obstructive sleep apnea, ineffective.
But it doesn't impact you at all during the day when you eat or have hard time swallowing? There's,
Not
the two
necessarily.
aren't related?
Not necessarily in that way, but there are daytime consequences of nocturnal obstructive sleep apnea, for sure. But that's the reason why the cardiology group and Dr. Satterfield indicated there are neuropsychiatric manifestations which would include obviously the memory issues, the fatigue, sleeping, and so on and so forth. In terms of the upper airway, there is, due to repeated episodes of obstruction, some swelling at the back of your throat. So in a conceptual pattern, yes, I guess you could argue that it could be, but I don't know, as a direct correlation, it should definitely affect your swallowing.
Okay, as a follow-up, then how does restless leg syndrome tie into sleep apnea? Because we're talking up here and then we're talking restless legs. Doesn't seem to go together.
It's obviously, as a sleep physician, although majority of our bread and butter is obstructive sleep apnea, which is 80% of the cases, that's why we exist in first place. There are other conditions of sleep, including restless leg or limb movement disorders or narcolepsy, so on and so forth. Insomnia, for example, being as common as obstructive sleep apnea. Diagnosis of RLS can be comorbid with sleep apnea, can occur with sleep apnea, or can be independent of sleep apnea, but can cause the same effects the next day. Meaning, if your sleep is disturbed, then you would have some fatigue and so on and so forth.
Are there anatomical, so I know my whole family suffers from sleep apnea and they have CPAPs, but are there anatomical structures that you could be born with? For instance, my one sister moved from a CPAP to a mouth guard apparatus that helps her the way her chin is made. Can you speak about that?
Yeah. So there is some inheritance factors for sleep apnea, which are, if your parents did snore, more likely you're going to snore. That's to do with the bone structure that you inherit from your parents. And in essence, the obstructive sleep apnea is a mismatch between your hard bone structures and the soft structures, for example, tongue or tonsils being enlarged. So yes, there is a hereditary component to it, and that's to do with the bone structure. And let's say some people who have, I don't know what the common word would be, retrognathia, for example, which is a mandible or lower jaw that's set deeper or smaller, or some people with some syndromes with have short mid-face called Robbie-Perry syndrome. And all those things would definitely be a part of why one would develop sleep apnea. Other example being an overjet. If there is, when you bite your teeth, if there is a space between the upper and the lower teeth, that's called an overjet. And that is also a predictive factor for sleep apnea, so to speak.
So Dr. Poteni, I threw up a picture here. Oh. So you'd be talking about sort of back here at the back of the throat when people lay down, that some of these structures kind of collapse on each other and close off the airway back here. Some of the things that he was referring to.
That's pathology, the soft tissue obstruction.
Thank you. I'm glad she brought that up about the throat. So tonsils, if you still have your tonsils, or tori, you know, in your bottom of your jaw, those will have an effect, or is there there is a correlation?
I mean, if you have a huge ping pong ball like the tonsils, yes, they would. But in adults, typically tonsillectomy is not considered the sole indication. It tends to be, the obstruction tends to be at a multi-level, at the back of your nose, the back of your throat, and so on and so forth. In adults, in children, taking out tonsils is the primary and the first treatment. In adults, unless they are really huge and they are touching in midline, the effect seems to be somewhat less prominent.
My question is, what are the treatments, the other treatments other than just the Cpap machine?
So other treatments other than a Cpap machine.
Common, like I just told in children, tonsilloadenoidectomy is the first one. In adults, it's not considered standard. Besides Cpap, we have to think about what's the severity of sleep apnea. For example, it's a mild or moderate sleep apnea, or does it get worse on the back as opposed to the side? Those features, some of them would predict what's called an oral appliances, like the lady was referring to. They look like Invisalign clips that you can put onto your teeth, and they pull your lower jaw forward in your sleep like that, and that creates some space at the back of your throat. That's the second most common. Then there are, besides obstructive sleep apnea, there are different kinds of sleep apnea. That's central sleep apnea, where someone can just use oxygen, for example. There are some medications that would decrease the frequency of sleep apnea. In adults, surgery can still be used. The definitive surgery that will cure someone of obstructive sleep apnea is called a tracheostomy. Basically a hole in your neck, like you're bypassing all your upper airway, so you're cured of it if you have a tracheostomy. There are mandibular advancement surgeries which are quite extensive. That's perhaps not really indicated, very minority of people. Finally, there's also newer approaches is to what looks like a cardiac pacemaker. There's a pacemaker for a hypoglossal nerve stimulator, that's called, that would keep on triggering the back of your throat, so it would prevent the collapse and keep it constantly activated and the airway open. Those tend to be the commonly used treatments for sleep apnea.
I was wondering, does sleep apnea and heart disease kind of tie in together? Or is it an indication of heart disease?
So sleep apnea doesn't lead to heart disease in and of itself, but a lot of the same risk factors that have you developed sleep apnea, like obesity is a big risk factor for sleep apnea. You can also develop hypertension and diabetes. And so those things are also risk factors for coronary artery disease. Sleep apnea also causes you untreated sleep apnea causes you to be at higher risk for atrial fibrillation, and also makes atrial fibrillation harder to control, and it makes hypertension or high blood pressure harder to control with medication if it's untreated. So, thank you.
I hear obesity mentioned as sometimes a contributing factor. So if a person loses weight, would that help the sleep apnea condition?
Yes.
How much would they need to lose?
Depending on the gradation of their obesity, I guess, and their severity of the sleep apnea. In mild to moderate cases, a weight loss of around 10 to 15 pounds is considered significant, again, in mild cases, but someone who is perhaps really big or has real severe sleep apnea, around 20 kilos has shown, or 30 pounds or slightly over that, has shown a significant improvement in AHI and sometimes resolution.
People that lose a lot of weight or gain a lot of weight, even if they're already on CPAP, sometimes need to come back for retitration so we can lower the pressures that they're on, or they may need to increase the pressure if they've gained a lot of weight over the last few years.
Tendency to eat more if you don't sleep right, you know, during the night, you get up, you feel hungry, you want to snack on something or whatever.
That's a whole nother sleep disorder.
That's correct. It's nocturnal sleep eating as well as irregular sleep-wake patterns that you're describing too. That's not truly necessarily direct correlation, but biochemically speaking, yes, obstructive sleep apnea and even lack of sleep like insomnia are associated with changes in hormones like ghrelin and leptin, which are the chemicals that are associated with our satiety center or appetite center. So the satiety hormone is decreased in obstructive sleep apnea, insomnia. And so there is some biochemical evidence that it does affect one's appetite and metabolism for that matter.
How do you go about changing the sleep pattern once you get into it, you know it's not good? I mean, it's like, you know, you're sleeping in the daytime, you go to bed, you get 2 hours sleep, you're up, stay up 3 or 4 hours, and you toss and turn, and you still may be up more, and then next thing you know, it's the sun's coming up and you're ready to go to sleep.
You need to see him.
So how do you get out of that?
Insomnia is as prevalent as obstructive sleep apnea, I guess perhaps more. The trouble that you're saying is insomnia, which could either be trouble falling asleep or staying asleep or irregular sleep cycles because of daytime naps and stuff. So obviously quick response would be, well, we just give some medication, but medications do not last long in their efficacy. The primary treatment for insomnia is something called cognitive behavioral therapy for insomnia, which is a series of behavioral changes as well as some conditioning of your brain to sleep. And some of this can be delivered online, such as there are some programs that you could be on computer, because there are not enough, as a practitioner, I would not have enough time to actually engage in CBTI because that needs daily sessions with you, right? And there are not much providers outside, like a counselors or someone that would give you CBTI. So nowadays there are online CBTI platforms which have been shown to be helpful by randomized trials. So to answer your question, CBTI would be the way that you can change.
I had 3 stents put in my heart 5 years ago, and now I'm wondering if maybe it was because I have sleep apnea, because my son and my husband say I do. I have a large, enlarged uvula. The doctors looked at it, he said it's just enlarged, there's no cancer or anything like that. But I have a hard time laying flat on my back and being able to breathe. So I sleep in a elevated bed or on my side. And I really think I might have apnea, but I guess the only way to find out for sure is to see a doctor. Yes?
Yes.
And start with your family physician.
Okay, all right, thank you.
In terms of your question about the stent and the sleep apnea, it's hard to say someone just healthy with sleep apnea like Mr. Untitled Chapter spoke to, that they just gets from this one. But it has been shown that there is increased plaque buildup in someone who had sleep apnea because of lack of oxygen and reoxygen can cause some inflammation in your body, which accelerates the plaque progression. So there's more evidence of the stents not lasting as enough, or they may have more blockages or newer blockages if they have sleep apnea and left untreated.
Recent studies, like you said, just to add on to that, recent studies have shown that they did studies on patients who had heart attacks, and those who had treated sleep apnea did much better than those who had untreated sleep apnea or were not as compliant with their sleep apnea treatments. And so that speaks definitely to the inflammatory, markers that he was talking about. But in the short term and the long term, the patients who had treated sleep apnea did basically as well as patients with no sleep apnea who had a recent MI. So.
Okay, Billy, I need to know what else options on CPAP besides just the mask? If there are nose prongs or different type things?
There's several different masks that we can use. Yeah, they do have nasal prongs, the full face mask, and then the mask that goes just over the nose. There are some other, I don't know, I might have to ask Mary about this one. There are some other oral ones that they've tried that just go in the mouth, but I don't know that those are really
We don't
around
use those. There are some new, they call them hybrid masks out. They cover your mouth and they sit right underneath your nose. And we've been having pretty good luck with those.
There are always new advances in other, companies that have different type of patient interfaces that go, different masks that are coming out all the time.
Is a couple questions. Is snoring in and of itself an indication of sleep apnea? And second question, if you have sleep apnea, will you always have symptoms of tiredness through the day?
No. Simple as would be, but yes, snoring does not equal to, but snoring is the, one of our, should I say, most common symptom or whatever that patient or spouse might notice would be loud snoring. To put it another way, obstructive sleep apnea. There are other kinds of sleep apnea. Obstructive sleep apnea is quite rare in absence of snoring. The other question that you had was, would you always have symptoms? No. Even someone who have rip-roaring sleep apnea, that they quit breathing every 30 seconds, might perceive their sleep to be uninterrupted, restorative, and they don't have any sleepiness. On the other hand, who has really mild sleep apnea, maybe extremely tired or fatigued and can't stay awake during the day.
So I have an interesting question for you all, and I'm not looking for a diagnosis, but 15 years ago I had a sleep study done. And they basically said that when I sleep, because I acted out my dreams, my mind just did not disconnect from the body. And I've actually injured myself several times When I became remarried last year, my wife said that I snore. So I went to my family physician. He sent me to an ear, nose, throat specialist who I had a sleep study done. Apnea was not part of that, but I do snore. I fall asleep like immediately, and I do not remember anything until I wake up. Do you all have sleep specialists here locally? Because the one that I was trying to get into did not see me till next year. So I think there is, okay, great. So my thing is, yes, the snoring is an issue for my wife. However, when I'm told in the morning, do you remember last night? I do not remember walking, I do not remember talking or acting out dreams. So it is a concern of mine from a safety standpoint and a physical standpoint to get this issue somehow resolved. I am taking medication for 15 years for what was diagnosed 15 years ago, but I know there's probably more advancements. So with that being said, is there...
May or may not. What your symptom that you described is something called REM behavioral disorder.
Yes.
Or the other symptoms that you're describing can broadly be lumped into parasomnias. In terms of sleep specialists, there are 4. Although we go by pulmonologists, all of us carry both specialties, sleep medicine as well. I'm talking about both here in St. Francis. All of them are both certified and are sleep specialists, although I guess we are not advertised as a sleep specialist. We would be.
Does that sometimes fall under neurology also, or?
Different. I mean, when the field started, there was both pulmonology as well as neurology that took the case. Meaning, some of them you can even specialize from pulmonary, you can specialize from neurology. Majority of the centers in US probably it would fall under pulmonary, but around 20% is neurology based. For example, St. Louis is pulmonary, St. Louis University, whereas Washington University would be neurology. Mayo Clinic, it comes under pulmonary. I don't know what. So I guess majority still would be under pulmonary.
My question goes back to the plaque buildup, the excessive plaque buildup. What about restless leg syndrome?
That's a really good question. So nighttime leg symptoms don't have anything to do with the vasculature. When we're talking about peripheral vascular disease, that's getting pain or cramping in your legs when you're walking and active, and that goes away with rest. Nighttime leg cramping or restless leg is not a vascular disorder, it's a neurologic sleep disorder.
No on the plaque buildup.
No. What she meant was it's not a manifestation of a heart disease, but can it lead to newer studies showing the RLS or PLM can cause, or it's a correlation, meaning you're at high risk of maybe developing high blood pressure compared to someone who doesn't have restless. But it's not as strong correlation or as well established as obstructive sleep apnea.
Oh, the home program, is that covered by insurance, especially Medicare?
Yes.
It is?
It is, but there are some limitations with that. The home sleep study only checks for obstructive sleep apnea. It does not, there's no heart monitor with it. We can't see what rhythm your heart's in. We cannot see if you are having leg movements or like room behavior disorder, acting out your dreams. If you're up walking, talking, we can't tell that. We can't see your brain waves. So that is just a very, very basic screening tool for sleep apnea only. So if you have any other medical conditions, like a heart condition, diabetics, there's several other, anyone who has several other health issues going on probably should try to get the in-lab study approved.
So does sleep apnea have any connection with sleepwalking?
The sleepwalking and other, they're lumped into what are called parasomnias. Parasomnia meaning some abnormal behaviors like sleep eating, for example. Sleep talking used to be, but it's no more considered abnormal. It's considered normal variant, just talking. But if you're talking out and acting out your dream, then that's different. Any condition that would increase the sleep disruption. If someone has sleep apnea, their mind is constantly switching between sleep state to wake state. That gives them a state of instability, so to speak. Anything that would increase that switch from sleep to wake, would cause an increased incidence of parasomnia, for example, sleepwalking.
So once you've then been diagnosed, going through the studies, and you choose to do the CPAP, how long do you have to wear that? Like the rest of your life?
Well, there's the weight loss, you know, if that is an option, you can refer to ear, nose, and throat to see if there's anything that they can do surgically, or the dental device if it is a mild case. But usually, most of our patients do wear theirs.
And I'll say too that most people don't like the idea of wearing a mask like that the rest of their life, but people feel so much better when they come back to see me, they wouldn't want to do it any other way.
One thing I've heard people talk about, do you have folks that do sort of combination therapy where they might wear one of the mouth guards to pull their lower jaw forward and a mask, or?
It's the combination would, like Mary told earlier, would help us decrease the pressure. Some very minority of patients would do that because it's double expense, obviously, even though insurance would cover it, but still it's dental appliance, a copay for that, as well as a CPAP. If you can give enough pressure with CPAP, most obstructive sleep apnea can be controlled. The only issue to combine it is if someone cannot tolerate the high pressure, then you're trying to lower the pressure with oral appliance.
Okay, because I know some people I hear people talk about dentists sort of talking about that a lot of times with their patients about having mouth guards and things that can help with that, but I don't know how often the dentists coordinate with the other care providers.
We do refer to some dental practices here that have more patient experience in terms of doing it. Most dentists perhaps could say they could do it. It's not just about fabricating the device. There's a certain art to it as to how you advance it, how tight it should be, what are the complications, how do you deal with the complications. Those things are more intricate. In fact, there's actually a sleep dentistry fellowship and a board. None of local dentists have that certification. So I would say it's not a generic piece of dental guard or whatever that you have to be. It has to be quite specific. You should have enough teeth for it to pull your jaw forward. So if you're missing a lot of your back teeth, such as your molars and stuff, they have to do extensive dental implants and stuff like that before they can do it. So overall, it tends to be more expensive because of those factors.
Is there can your sleep or your breathing rhythm slow down? I mean, how slow is normal? Is there anything normal about a slight gap in an exhale, a half second, so before you inhale, whatever?
And
What's normal?
Most people would breathe around 16 in their wake state, perhaps slightly lower in their sleep state, so to speak. But it's more to do with the depth of breathing. When we sleep, we don't perhaps breathe as deep, not necessarily as much as how many times we breathe. That perhaps tend to be around the same, maybe just a one or two low. For anyone to consider sleep apnea, the pause has to be at least 10 seconds. That's one of the criteria. So that's almost like 2 breaths of a normal breath. If you don't breathe for that long, then we count it as a sleep apnea, not necessarily just like 0.5 seconds or a second or 2 or 3. 10 seconds is the minimum time duration of any event.
So what would be the symptoms that would cause you to have a sleep study done, for example? And I had, years ago, how long was it? Gosh, 15 years ago or so, had a sleep study done when I was driving over the road. The guy that did the sleep study sent me out of the hotel with a Cpap the next day, and I suspect that everybody that did a sleep study did the same thing. But since then, I've had my nose worked on, and it's like somebody opened the door. I can breathe now. But and I think I sleep fine, but I'm told that I stop breathing. So what symptoms should you look for?
Remember we said that it could be completely asymptomatic and just noted incidental, while it's not uncommon for me to see patients that are referred to me because they had colonoscopy, for example. Under sedation, they were snoring. They never thought they had any trouble. They come to me. Right after surgery, they come to me and they say, well, I didn't think I had a trouble, but they said your oxygen was going low after hospitalization for whatever issue. That's what. So in general, while Dr. Satterfield said, symptoms can be anywhere from fatigue, excess sleepiness, memory issues, waking up nighttime to pee a lot, early morning headache, sleep in general not being as refreshing in quality, to completely asymptomatic and something that's driven by, for example, there's a high blood pressure being difficult to control, or AFib difficult to control, or someone witnessing an apnea, so on and so forth. Motor vehicle accidents, for example, we do nowadays see some companies trying to promote this to, if there is certain risk factors, for example, if you snore or have a large neck or high BMI or being obese, for example, you are automatically get a sleep study. If you are on a specific occupation, such as if you're a driver, for example, or a pilot, so on and so forth. It doesn't have anything to do with symptoms. It's great.
What do you suggest about cleaning this machine? And also, do you think that's so clean that the advertise works all right?
It works all right, but the insurance doesn't pay for it. It's, I guess, a few $100. In terms of...
$350, I think, is what they're going for.
Could be. So, both are good if you have an adequate upkeep, like the company recommends at least twice a week, if you can run it with soap water or and complete, hang it to dry and keep the where the heated humidity unit, if you keep it dry and then put some water back in. If you maintain it adequately, I don't think it's so clean machine is superior, but it just takes work out of you. So
Even with the soap clean, you still have to clean your mask or it will get, those oils will still build up and it'll slide around and leak. And they do make wipes they actually make Cpap wipes for those masks. But soap and water work fine too.
So how does Social Security insurance look at the CPAP as far as coverage?
Medicare, Medicaid both cover, and then if you have a supplement, usually you have very little out of pocket.
Is that also the study? Does it cover the study?
Social Security does cover the studies?
Yeah, Medicare and Medicaid both definitely cover the study.
The duration of the study is, if you go in for that, that's a one night, or?
Well, Well,
multiple nights?
it can be 2 nights. We first have to have adequate time to diagnose that you do indeed have sleep apnea. And it has to be a certain level of severity before we can put you on the Cpap machine. So if you don't meet that criteria the first night, then you could be referred back for the second night, which would be a full night to regulate the pressures on the machine.
In regards to the CPAP machines, obviously I know it depends on what type of sleep apnea you have, but is there a gradation on machines, meaning maybe your insurance covers CPAP A, but CPAP B is a little better, and if you pay a little bit more, do you know what I mean? Are there levels, would you say?
Not that I'm aware of. Some insurance companies do have preferred medical equipment providers though. So that would be something that you would want to check with your insurance company if you did find out that you needed a CPAP machine or a Bipap machine. They would let you know which area companies, if they do have a preferred provider. And when we discharge our patients, we always discharge them with a list of, we can print out by county for Missouri and Illinois, all of the equipment providers for your home county. And then you have that list when you call your insurance company.
So you would say they're all equal in
Machines
Or the payment, you mean?
No, the quality of all the machines.
Quality of the machines.
Well, we use 2 different types primarily, but that part is not really up to us. It's what the home care provider carries.
I have 2 questions. If you're going to get the dental appliance, is that ran through your dental insurance or is it ran through your medical?
I usually give them a script, a signed script, and advise them that the dentist should work with the medical insurance part of it.
Okay.
And for that reason, that's again, I say we have some few dental offices that are more comfortable doing that way.
And say that I do get either the dental appliance or a CPAP machine, how long before I start to feel better where I'm not so tired?
CPAP machine usually a matter of, some people will feel just waking up with the CPAP, say, well, it's a really good night, the immediate first night. In fact, they do, when we do sleep studies, we often show that they go into what is called a rebound sleep, meaning deep sleep that they were missing because of the sleep apnea, that what we call delta sleep or sometimes REM sleep, that's rebound after CPAP. So in those people, they would immediately notice the first day that they would get benefit. As a rule, in general, majority of them, 80 to 90% of them based on studies would have a positive impact at the latest 5-6 weeks.
Just to add to that, patients who have hard to control blood pressure or atrial fibrillation, they tend to get quite a bit better quite within that first couple of weeks. They're calling our office saying, hey, I started a CPAP and now my blood pressure is dropping too low on all this medication. That's happened before and they've been able to go off multiple medications. So.
You may have explained it, maybe I missed it, but what's the difference between CPAP and Bipap?
CPAP is one pressure, one constant pressure, and that only goes up to a certain amount of pressure. And some people require more than that. So then at that point, we would go to the Bipap, which is 2 different pressures. Some people are just unable to tolerate the straight blowing constant Cpap, and then we would switch them over to the Bipap at the beginning, and they seem to tolerate that a little bit better because it feels a little bit more natural because it's 2 different pressures. It feels a little more natural in the in and out.
Any other questions? We're just about finishing up our time here, so we'll.
Did you have any other alternate than our Cpap and all other apparatus? Did we find any other less invasive kind of technology or to apply?
In addition to what we already talked about, perhaps maybe 10 years down the line we would have some other, because they're trying to subgroup patients with sleep apnea, those that have trouble just with anatomy, some people that have more trouble with their reflexes, meaning if their oxygen is going low, why is not that the body is trying to respond more robustly than what we see? And there are some people that would have, well, I guess it gets more nuanced, so it's difficult to explain in simple terms, but they're trying to phenotype. It's the workup currently is being researched as of now. So maybe in future there may be some pills that would come up for certain people with sleep apnea. But like I said, we are way out from there, almost 5 to 10 years from now.
Because last month I have heard on the ABC News, there was some kind of less invasive technology done to the nose, and they opened the airways, and this solved the problems. You know, I don't know. I didn't go to detail, but that was a short news. Some is done in some Columbia University, New York, or somewhere.
There could be all kinds, but I don't know. There's something called a sleep-induced endoscopy where they actually give you some medication that makes you sleepy and put a scope down to see where the level of obstruction is. Based on the level of obstruction, there are a whole host of new kinds of treatment. And in the past, they used to trim all the structures at the back of your throat completely and say that's surgery. Nowadays, they're trying to personalize it to where the patient has a trouble. Sometimes they can flip the soft tissue up instead of trying to completely trim it. So there's many variations of that upper airway surgery that are done, depending on, I didn't see that episode to elaborate further what you are referring to in particular.
Alrighty, well, we'll kind of wrap it up. Is there anything that any of you have that we didn't touch on that you think would be pretty important to throw out here before we finish up?
Nothing we do in the sleep lab is painful.
Nothing we do in the sleep lab is painful. And we have a great sleep lab that accommodates, they have facilities that accommodate all sorts of patient types and things. And so they do a great job, whether your insurance maybe have you start with something simpler, but ultimately if you need that, they're really good at it. And they've got a really nice facility up there, so.
Yeah,
Well,
our sleep lab is accredited by the American Association of Sleep Medicine too. So that's something you want to look for in a sleep lab. I know somebody mentioned something about going to a hotel room and having a sleep study. If you want to make sure you're going to a lab that's accredited, that has the best equipment, best trained staff, the best ability to follow up with a pulmonologist, you need to ask for one that's been accredited by the American Association of Sleep Medicine.
Well, that makes me think about, sometimes we see these storefront things with sleep labs and that. So is there anything we need to say about like who's reading those studies, the level of certification and training on some of those?
Well, I guess I answered this in part before. It's a current stand from American Association of Sleep Medicine is that someone who reads or interprets this data is trained in sleep medicine for an extra year of fellowship, which, like I said, most of us are, at least the ones that are practicing here in Cape. Those are the ones that are doing some of those facilities. There are automated machines that would go through your data and spit up a number that may or may not be an actual representation of what's going on. So while there are a lot of technology that is available, there's a limitation to that, and translation of that data into patient care is also a problem in automated, downloads or automated sleep labs where they don't have this interface with the physician actually reading their interpreted sleep studies and actually trying to say this perhaps might benefit more. For example, while majority of us would still say CPAP is a way to go, around 10 or 15% of the time we would say that's perhaps not doing as much good. You probably should do alternatives. That's from our lab, from my personal thing. For example, oxygen alone might be as sufficient, if not CPAP. That information you would not have if some automated software would just glean the data and say, well, you need the CPAP 50 to start using.
We have 3 physicians that read, Dr. Popanini, Dr. Khan, and then Dr. Robert Gardner Jr. also reads for us, and they're all 3 board certified. When the report comes out, of course, they condense, those pages and pages and pages of raw data, but they also make recommendations for treatment. So like when Dr. Popanini reads, that goes to Dr. Satterfield, and he says, okay, this is what Dr. P says we need to do, so here's our plan. And then he sees the patient back, and they go from there, based on a board-certified sleep physician's recommendations.
Actually, when I order my sleep studies, I have a standing order that all of my abnormals just get directly referred to either Dr. Popanini or Dr. Khan, because they are the sleep specialists. That's what they do. They manage it from there. So I wouldn't want that any other way for my patients.
And that just comes down to having a team approach of people that all sort of do their specialties, but they coordinate together to make sure that things are tailored to you. So it's great to have a great team of people like that in all the different disciplines to cover you and make sure you're getting what's specifically better for you rather than a cookie cutter approach. Well, let's thank the panel for their time and their expertise. They've been awesome. And I brought the basket in here so I wouldn't forget to do the drawing. So we'll shake it up here, and I'll put Dr. Satterfield under pressure and let him pick a number out of there. All right, so the number is 518726.
Oh my gosh, that's me.
Well, we have a winner. That's great. Well, listen, folks, thank you again for coming out. We appreciate you all supporting these seminars, and we hope you got some good information. Thank you.